This is an extremely hard cataract, much like what we are seeing in this COVID times. So I planned for a phaco. I know I'm going to have a lot of trouble. I've made my incisions and stained the capsule with trypan blue. And I plan to make a largish rexus, as you should in all these hard cataracts. Don't make small rexus and then try to do a phaco. It's very difficult. And I know this pupil is going to give me trouble. However, right now it's dilated, so I'm going with it and hoping against hope that it will not shut down. But that's too much to hope for. In my experiences, these pupils are not very surgeon friendly. So anyway, here goes. I have done my large rexus. At least the first step is okay. You gotta take these cases one step at a time. They're very difficult. Don't rush. Don't rush. And I'm doing now that I could see the nucleus moving forward. That's enough, I think. I just rotate with the tip of my hydrodissection cannula, and that's more than enough. You don't have to hydrodissect it anymore. And just watch the pupil, it's already coming down. And I put in some sodium hyaluronate as well. You do need to protect the cornea. And I am obviously going to do my direct chop method, taking a very sharp chopper, very stout chopper, and I'm around 80-85% phaco power. I'm at 400 millimeters of vacuum and 40 ml flow rate. And I'm going right from the mid periphery, trying to go across to the center and bury my tip. I think I should have buried a bit more anyway. So I have got a chop, but yes, there's a lot of attachment. Incidentally, this patient is also a diabetic, which makes it worse. They have such hard, leathery cataracts. And okay, the next one, I definitely make an effort to go deeper, impale deeper, and laterally separate. And yes, I was successful partially, but look at the pupil. The pupil, it is floppy as well, and it's just coming down. However, since my chops are all central, I'm not going to come out as yet. I will make as many chops as I can. And it's very important. Just get it. And back of my mind, I know there will be a spine. There's no way there cannot be a spine. So it's okay. We can still manage, and I'll show you how I did it. So just make sure that you impale deep and get a very good hold. Go in boldly with your chopper. The chopper is only 1.52 mm, nothing great. So then this nucleus must be 4.55 mm easy. So there is no way you can go anywhere near the capsule, and try to do this multiple separations. You can see that central disc. That's what I'm going to target. I'm planning to target that central disc and bring it out, so I know what's happening in the center. There will be a spine behind it, there's no doubt about that, but I will worry about that later. So still I'm able to see the posterior capsule, and I'm also able to see the backbone. So making multiple chops, I made around 6, 7, 8, I don't know. And now I can see that the disc is sort of lifted, so I'm trying to bring it out. Now see, because the pupil is shutting down on me, I have to retract my phaco tip in order not to catch that iris, and I am hydrating my wound in the process. So now I decide enough is enough. I've got enough of my chops. I'm going to now put in these iris hooks, not just for exposure, but if I try to do the phaco with a small pupil, I will be forced to bring these segments over the iris, and that is too dangerous for the cornea. So once I have exposure, I can just about bring out a segment like a clover leaf and emulsify it in that place out there. Just watch that. I am staying almost within the capsular bag. So although I don't have completely separate segments, this is enough. And once this rotates, See, watch, once I get a clear area, one heminucleus almost done. See now how this will tilt towards me. This is still the first heminucleus, a very large nucleus. See, it tilts towards me and that attachment comes into my phacoprobe. And look how everything separates. Now, and watch my phacotip. Tip is always facing posteriorly. It never turns anteriorly. And that's it, it's done. It's less than 30 seconds, which is very good for such a hard cataract. And mind you, check very carefully. There's no cortex, hardly any, nothing. And there's a small bit, maybe a nuclear bit or an epinuclear bit, whatever, it's all nucleus. Don't try to mechanically take out this. It's better just put back your phaco probe and give one zap, and that's it, it's done. And then under HPMC, I'm going to implant my single piece hydrophobic IOL. Just making sure that I place it within the bag. And that's done well. I then proceed to remove the iris hooks atraumatically, and that's a good pupil. It's many times these iris hooks can distort the pupil, but it hasn't done so in this case. I finally remove all the HPMC, and that is a floppy iris. And once the HPMC is removed, I hydrate the wounds, put in my intracameral antibiotic, and conclude the surgery.